All right, thanks for having me. Is the first thing I'd like to say to whoever it was that originally organised it. I think we just sat down one day and had a discussion that it was an opportunity to come out and talk. I also promised Dr. McDonald that I'd have less than 10 slides, and I've delivered on that because I've got 9 and one of them is the title. And as a dietitian, I'm not going to keep you from lunch, so I'm going to roll through things. One of the I guess the theme of what I wanted to talk about is just to give you a little bit of a idea of what's going on in the nutrition research circles in people with kidney disease, and that's across the spectrum of chronic kidney disease, dialysis, transplant. I will be fairly forthright as well, I promise, because there's no point beating around the bush. The thing about nutrition research is there's still a lot of work to be done, and I think what we're starting to see, at least the push, is coming from this cultural change of actually wanting to think about nutrition from a different perspective, and particularly from the patient perspective as well. So the first important thing is, I guess, for us, picking the difference between what is research and what's literature, what's commentary. And there is a lot of sort of review done in sort of nutrition things, and not always a lot of new things coming out in some areas. We will be having some new international renal nutrition clinical practice guidelines coming out hopefully in the next 12 to 18 months, but the problem with them is that they're going to be seriously flawed. We know this already. And it's a little bit frightening, so I'm just making you a bit aware of it, because what has happened is we've got, unfortunately, people overseas who don't have this same patient perspective that I think we have here in Australia. Their approach from the evidence point of view is find things that work and only really high-level evidence, and really have ignored a lot of the things that are actually coming up through the literature, which I'm going to talk about in a second. They're not particularly patient-focused. They're more sort of, what they think are the outcomes. And it's ignored a lot of the things which we think are actually pretty important. So this is going to be a big challenge for us, because we're going to need to translate it, obviously, and defend it, and defend our position from a nutrition point of view as well. Renal nutrition literature is still, unfortunately, being dominated by malnutrition or nutrition status. And unfortunately, though, there's lots of really poorly done studies and nothing particularly new. So this is a bit of a sort of area to move on quickly from. But unfortunately, what has happened is that a lot of this has been generated out of the US with a very different medical system to what we have here. A lot of people sitting behind desks and computers looking at big data and trying to pretend that that's actually, what's important. And sure, they've got lots of numbers. You could have 100,000 people in a study necessarily, but it's not actually going to patients, asking them things like, what are you eating? How are you eating? Other symptoms, other influences about what you're eating. It's just things like serum albumin levels, which I'm here to tell you is not a nutrition marker. So if you're part of maybe a study where you're a consumer sort of advisor to those sorts of studies, be very wary if people are putting albumin down as their marker. You can pull them back into line, please. What's important, though, is people are sort of using these pseudo markers rather than actually looking at food intakes. And that really bothers me, because we need to be looking at what people are actually eating, not just blood tests. One thing that is really positive, and it is a bit of a cultural change that I think is a really positive thing, is that plant-based eating, and that's a sort of a term for more vegetarian type of eating, not necessarily veganism, but including more plant-based foods, plant-based proteins, has had renewed interest in the literature over the last 4 or 5 years in particular. And this is really positive from a patient point of view as well, because in the past, eating things like legumes, for example, or eating extra fruits and vegetables is really, I guess we push people well away from that for this fear of potassium being too high, for example, or all these other things. And it really came at the cost of a whole pile of other things, such as gut health and even basic things like how easy it is to formulate meals and menus and how to enjoy food, really. And that's something to me that's really, really important, is if you're not enjoying your food, then we're not doing this properly. What the plant-based eating has shown is that we're seeing improvements in acid-base balance, and that's an important thing from a clinical point of view, maybe not something you necessarily experience on a day-to-day level. What it's also leading to is naturally lower protein intakes in people with chronic kidney disease. One of our objectives is to try and keep protein intake fairly low because it reduces the generation of urea, which might lead to the symptoms of poor appetite and nausea and things that you experience as a as a person with kidney disease. So if we can minimise those sort of symptoms, that's a really important outcome. So this is one thing that we can certainly do. What we've also seen with this is, despite this fear that potassium and phosphate levels, for example, would go up, they don't. And they don't because they're actually fairly poorly absorbed from these sorts of foods. So we're talking about things like legumes and vegetables, grains. So it's actually having really positive benefits as well. We see improvements in levels of phosphate and other hormones related to this chronic kidney disease mineral bone disorder, which is an important long-term clinical outcome. So, there's a whole lot of positives here as well. One of the areas we're quite interested in is gut function, and of course, if you're including more of these sorts of foods, you've got potential to improve gut function significantly. And I was interested, looking at Martin's slides there before, of all of those things on the list, there was nothing about gut function. So just a heads up that we probably should be including that as well, because it's an area that's a very common patient-reported sort of symptom to us as clinicians, particularly from a diet point of view. So, there's big benefits to that. And that better gut function potentially means better immune function, and there's also quite a bit of really solid evidence coming or come out of Australia, particularly in Queensland, where reducing down the generation and absorption of uremic toxins has been shown by improving this, or sort of including more plant-based protein in particular. So a whole pile of really positive benefits. What we've got to get, though, is people to actually understand this literature better, and that's clinicians in particular, and take this on board. And it might take a little while, but it's certainly something that we're going to push for. The other thing that is really important, and it's starting to seep out into the literature, is just reminding people that at the end of the day, we don't eat nutrients, we eat food. And a lot of nutrition-related research has been focused on, how much potassium you've had or how much protein you've had. But that doesn't tell us anything really about what you eat. Because, for example, we could have someone on a low potassium diet, but all that potassium might be coming from dairy foods, for example, and you're getting no fruit, no vegetables, and missing out on whole food groups, and then missing out on all the other nutrients that potentially come from those foods as well. So we need to have that dietary balance, and we need to have research that's actually looking at what people are actually eating in terms of their food groups, the quality of food, and the holistic picture. And it's starting to be done, but that again is going to take time. It's also important because we're looking at eating patterns, and that might be the idea of, say, the Mediterranean type diet, for example. But even when people eat, the timing of when people eat, and even is there better times to eat? Maybe from a dialysis point of view, there's a better time that might improve the response to dialysis, for example. These are questions that no one's even really looked at. So again, I've just put a little note there at the bottom that if you're a consumer advocate and looking at sort of study design and things like that, this is something that you should be raising and just reminding people that, hey, we eat food and we want to know about what we can eat, not just what the nutrients are. It also leads into some work that's going on, and it's certainly something we're very interested in, is gut-related research and gut function. So we know from our work that there's a lot of symptoms that people experience, and it's not just constipation. There's a whole pile of other things that we need to know a lot more about. And hopefully from a nutrition point of view, there's things that we can do that might actually improve those symptoms. And I think that's something that to me seems really important, because it's not necessarily about morbidity, mortality, how long you can live, etc. It's something that potentially we can improve on a day-to-day basis some of those symptoms that we know are related to quality of life, feelings of well-being, just general sort of enjoyment. So this is, I think, a pretty exciting area to work in. And it's probably been ignored. And from a kidney point of view, we're often focused very much on kidneys, but we're, I guess, opening up to the idea that other organs and other parts of the body are being affected by what we do in terms of treating people for kidney disease as well. So the microbiome, which is all of your gut bacteria and all of the conditions within your gut, is a area that's of particular interest as well to a lot of people. I mean, it's probably the biggest growth area in research in health across all forms of, I guess, health. So we're jumping on board that as well. But there's a lot to learn in terms of what's going on in people with kidney disease. So that's an area to watch. Of course, one of the things that people are always interested in is whether we can slow down progression of chronic kidney disease. And generally that's something that patients want as well. Nobody really wants to be on dialysis necessarily, as has been pointed out quite nicely before, is, you have a whole series of poor choices. Well, you've got to choose one eventually, but one of those also is things that you can do that could potentially slow things down. The gut is one of those targets, and so food is one of those things. But even if we're improving symptoms, that may be an important part of looking after people and preventing them from going on to dialysis as well. So at this point in time, there's nothing from a nutrition point of view that is absolute that says if you do this, you're going to slow down your rate of progression of chronic kidney disease. And I don't know that we're ever necessarily going to see that. I think what we've got to remember is symptoms are actually a really important part of managing with chronic kidney disease. If you do a quick search of the nutrition literature as well, this is just one of those other topics that is in there, and this is this use of very low protein diets and the use of ketoacids. Now, it might be something that's completely foreign to you at the moment, and I'm pretty happy saying that, because in Australia it's not something that we do. It's an idea that's being used overseas. It's being pushed primarily by, I guess, commercial interest, but it is something that I get asked about from a dietitian perspective. I get asked by dietitians overseas what's going on, and it's one of those things I say, well, I don't really know because I don't really have anything to do with it. But it is I guess, an approach that's been used in countries where dialysis is very expensive or there's very little access to dialysis. But at the same time, there's a massive problem with the literature with this. There's huge dropout rates with these ketoacid tablets and capsules that people need to take. There's a whole pile of flaws, but nevertheless, people keep pushing that this is a good idea and seem to be ignoring that. So hopefully this is never something we're going to be using in Australia, but if you read the literature, it'll make it sound like this is the latest and greatest and newest, best thing. The reality is, we think from a nutrition point of view, there's a lot of other stuff that can be done that is far easier to manage from a patient point of view, and enjoying food a hell of a lot better as well. One thing that is sort of interesting in this area as well, though, that's been largely ignored by the people pushing this idea, is that there are parts of the world, and I was recently in India, which is what's it, 20% of the world's population there, with about 90% people who are predominantly vegetarian, who generally have a reasonably low protein diet naturally. And the dietitians there are actually saying, even with people with chronic kidney disease, we need to bump their protein intake up a little bit. What we really need to learn from that is that you can do it with food. You don't need supplements. We don't need to be making life really hard. We can actually learn from other cultures and other eating patterns and potentially have some really fantastic benefits. The last slide is, I guess, what else needs to be done? Well, I could have put probably 50 slides up here about all of the things that still need to be done, because nutrition research is technically difficult and not always, I guess, as sexy as some of the more expensive sort of trials and interventions. But one thing that we really need to do is to consider the population of people that we have at this time. A lot of the nutrition studies, particularly around energy requirements, protein requirements, even things like potassium and phosphate, were done 50 or 60 years ago. And people with kidney disease at that stage were a completely different, being, really. I mean, we have had such advancements in terms of treatments, medications, dialysis, even a knowledge around transplant, immunosuppression, all of these sorts of things. But the studies haven't been repeated in people that, our current patient population. So there's a really important need to do these sorts of studies because unfortunately the data being old, I think, has become less and less relevant in this day and age. What we are dealing with more so now is overweight, obesity, heart disease, all of these other things that, elderly people on dialysis, frail, that just never part of the picture 40 or 50 years ago. So, there's a lot of work to be done, to be repeated. We can't just sit back and say, yeah, well, that was the proof 50 years ago. I think we've got to recognise that people are different, our population is different. And on that note, I'm happy to take some questions.
Thank you, Nancy. I really appreciate the work of dietitians. It's really tough in this area. I was thinking as you were speaking that we get surveys and I see research and it says, for instance, one slice of multigrain bread. Some slices of multigrain bread have 2 grains in them. Some slices are packed with grains. Imagine the difference in fibre and potassium. So I see that you have a point. I also appreciated your comments about the gut uptake of things and eliminating toxins. It sounds like there is more interdisciplinary research with gastroenterology going on these days, which is lovely to see as well. My own question was your comment about albumin. I've had low albumin forever. It seems it wouldn't matter if I ate 5 steaks a day, it wouldn't make any difference.
Yep, absolutely.
What does low albumin mean?
This is a whole kettle of fish. I could pull up a whole pile of slides. Albumin doesn't. What you've said there is exactly the reason why albumin is not a nutrition marker, because we can feed people, overfeed people, all the rest of it. Albumin doesn't change, and it doesn't change because it's related to things like being unwell, inflammation, infections, surgery, all these things. And there's some of those things for people with dialysis, for example, are chronic. Even chronic wounds, pressure areas, these sorts of things. It is more a reflection of how well you are. And so in a research point of view, albumin just, if albumins are good, it shows that you've got a fairly healthy population. If albumins are low, it means you've probably got a population that's got a whole lot of things going on. But it doesn't respond to nutrition intervention. There's still a lot of studies that will try and use that as a marker, but at the end of the day, the people in their studies have probably got better, and that's why their albumins have improved. Not because the nutrition caused their albumin to get better. Their nutrition might have helped them recover and get better, but protein, no. And look, I had one of our patients on dialysis who we talk a lot, and he's got a chronic sort of low albumin and took it upon himself to start beefing up his protein. He'd done a lot of stuff in the gym in the past and various protein things, and he got his protein intake up to 3 or 4 grams per kilo like a bodybuilder might. It increased his urea by about 3 times. So he was coming to dialysis with ureas of 45 and 50, and his albumin didn't change. And the urea is a better marker. That's where the protein is showing you that protein is being digested and broken down, is that urea marker. So yeah, it's going to be a long battle, really, to change people's thought processes about albumin. I've got a lot of challenges with colleagues to try and remind them that it's not important. And at the end of the day, if people come to me and say, look, this person's got a low albumin, can you see them? Yes, but is it because they're not eating very well? Yes, well, I'm not seeing them because they're low albumin, I'm seeing them because they're not eating very well. And how will I know if I've done the right thing, I'll be able to tell that they're eating better and that their overall intake is better, and they'll hopefully, get better with time as well.
Always amuses me to hear a dietitian talk about a different kettle of fish. Yeah, Anthony, there's an online question while Talia runs back to the end. An online question from Jan, who says it's very difficult to manage protein, potassium, phosphate. Do you believe an extremely low protein diet is relevant? And the second part is it feasible to source your protein from legumes which are high in potassium?
That's a very, very good series of questions, really. The reality is, I don't think there's any great benefit to making life impossibly hard to try and get an extremely low protein diet in, because it's not proven to slow the progression of kidney disease at all. And that's what I was really saying about plant-based protein. So legumes and lentils in particular are a fantastic option from a protein point of view in people with chronic kidney disease, and even onto dialysis as well. There is, the way we get nutrition information, like you might see on a nutrition information panel, and what we get in our food tables, for example, is we put food into what's called a bomb calorimeter. I've never seen one, I don't know quite how big it is, I just imagine it's this sort of box, and we blow everything up to ash, and then we take it into the lab and we assay it and we see what's actually in it. The problem with that is it just tells you what was in the food at the start, and that's what goes into the food tables. It doesn't tell you anything about how well that food goes into your body, how it's digested, how it's broken down, how much of it's actually absorbed, how much goes out the other end. And what we know with things like legumes and lentils is the absorption of things like potassium and phosphate is far, far less than people realise. And that's fantastic, because that's what helps in this situation. So there is no reason to be avoiding legumes and lentils and plant-based protein. There's actually a whole pile of advantages, and those are actually in terms of things like the acid-base balance, which in turn might improve potassium levels and keep them low. And what was interesting when I was in India just recently is every time I spoke to a dietitian, they were saying, we don't have problems with potassium, and we've got all these vegetarian patients. Yet in our part of the world, we have a lot more problems with potassium, because we've got people eating far more than what they need, most likely. But a lot of animal-based protein, which is acid-forming, more likely to promote a higher potassium, for example. And we see that in clinical practice. We can change people even out to 2 or 3 more vegetarian-type meals a week, for example, can make a huge difference to their levels. So, look, we can talk about this a lot, but it's an excellent question, and certainly I don't want people avoiding those foods, because you don't need to, and you should actually be having them.
Thank you, Jane. And one last question down the back.
Yeah, hi. I had nephrotic syndrome as a child, and I have PKD. I've also been plant-based for a few years now, whole food plant-based, and I'm an athlete. Yet every time I go to any sort of conference, symposium like this around anything to do with kidney disease or really anything else, and every time I walk into any specialist or clinician, I get interrogated, abused, etc., around my dietary choice. And that's before I even pull out the blood test results and everything else that show how much my figures have improved over the years. So my question to you is, when and how is this perception going to change? Because I know the scientific literature supports what you're saying, and that's how I came to it. But it is literally killing me that every time I see a clinician, I get harassment. And I mean serious harassment. So.
Yeah, look, I'm not surprised to hear you say that. And I'm really sorry to hear that, because that's incredibly frustrating to me as well. And it really shows, in some ways, a bit of ignorance from a clinician point of view, and not sort of keeping up with what's going on, and also not listening. And look, I'm incredibly frustrated. I would support you 100%. My email's there. If you've got any questions, email me, because be more than happy to prop you up anytime you need a bit of positive feedback on it, because certainly the evidence supports what you're saying, and what you can do. And I think the difference is, we're trying to get people to work together, and that's always been my approach. Is I'm not telling you what to do, I'm working with you. And that means sometimes bending, flexing, trying to make it work for you, and it's about individualising as well. And, you know, that means listening to what you want to do and making it work as best as possible. And certainly in a plant-based eating pattern, a vegetarian type eating pattern, for example, there is things you still need to be a little bit careful with, but we've still got to make sure that the balance is right, and it can definitely be done, and it can definitely be a good thing. And if I can do anything, that's why I'm here. You know, getting up, I'll keep banging on about it in my circles as well, to try and get people to think more openly about how we really individualise that. The other thing, just to add to that too, is we have an international renal nutrition conference. It's only every second year because I guess it's still a fairly niche field. But one of the researchers that had done a lot of the protein sort of research many years ago finally pointed out that there really is absolutely no basis to this idea that you need to have greater than 50% high biological value protein, which is something that's written into all of the guidelines. There's no evidence for it whatsoever. It was really just theoretical, knowing that animal-based protein is more sort of, well, it's easier to get all of your essential amino acids in one go. But that doesn't mean you have to. So it was in there, and people have taken that as gospel, and it's not. You know, hopefully we can change that mentality. Yeah, but by all means, if you want to know anything, email me. Love to talk.
Great, thank you very much, Anthony.